Hi dear colleagues, my name is Marian Fanica. We are still here in Poiana Brașov, still at Aesthetic Marathon, and we are going to talk a little bit about my favorite topic in dentistry, the one that it's by far the least understood by many dentists, that pose a lot of issues, and that's why we brought here a specialist in adhesion, in aesthetic dentistry and direct reconstruction, Gianfranco Politano. Welcome.
Thank you very much. In truth, I am here to eat the amazing dish called ciolan, the best Romanian dish they have. But I will speak about adhesive dentistry too.
Then we'll have some ciolan.
Yes.
Yes. What I want to ask you, because this is not a misconception, but this is and a hard point for a dentist to understand. Why do we have so many generations on the market? Which generation is the best? We have the fourth, fifth, sixth, seventh, now the eighth generation. Or,
yes.
I don't know.
Listen, I love to be very, very simple because I am a specialist. A specialist, it means that unfortunately I have to do the same things all the day, every day, for 1 week, for 1 year, from 20 years old. For 20 years. So I was born with 40th generation adhesive system, and in my opinion they are the gold standard in this historical moment. They allow you to make a lot of mistakes during adhesive procedures. And I love to continue to use this kind of adhesive systems for direct and indirect restoration. The real problem, in my opinion, the most underestimated one, is the selection of the tissues that you have to offer to adhesive and adhesion in a general sense. Because a lot of people don't take the right attention to the selection of the right tissues to be offered immediately after two adhesive procedures. So maybe a 40th generation allow you to make a little bit of mistake, but more you use modern generation, more you have to be more you have to pay a lot of attention on the steps that you are performing and on the quality of the step that you are performing. So it's not true that the last generation of adhesive don't work. It works and work very, very well, but they need to be used in a very correct way, following with big attention the instruction of the producers, the company. And please don't make the artist with this kind of product, because you will pay the cost with your patient with problem of sensitivity and other real clinical problems.
Just as a reminder for our colleagues that are watching right now, the fourth generation, it's the first generation that was well spread and used in dentistry. It's considered the golden standard, and you have all the components separate. You have the phosphoric acid, you have the primer, and you have the resin, you have the bonding.
Yes, I love sincerely to treat my teeth with acid, and I don't have fear to treat my tooth with acid, because I use a three-step adhesive system. So the next step, the priming step, allow me to compensate any kind of mistake in the etching procedure. So I love to use this kind of generation. And overall, the bonding, I love to use a high fillet bonding to increase the mechanical property of this very important layer called adhesive, because it's the functional base of the restorative that you put on the top of this thin layer. And I want a very mechanically performance layer, because it's a very stressed layer under mechanical point of view.
Okay, what I want to ask you about the etching procedure, because this one is critical. Yes. For example, if you have a class 1 cavity, you want to make a direct restoration there. For how many seconds you etch the enamel? How many seconds the dentin?
I don't believe in a separate approach to treat enamel and dentin, but from several years I treat all the cavity with a single increment of acid, and I treat in the same time acid and dentin for 20 seconds. I wash very well my acid, at least for 8-10 seconds, and I dry. Dry is not the correct word. I
remove the excess water.
Dehydrate completely the substrate, and in 50 seconds I arrive immediately with a lot of primer. The primer have the possibility to create a good physical and mechanical highway from the bonding that I will put on my primer immediately after.
For example, if you have just a small preparation, only in enamel, you want to make something like a Pitt and Fisher sealing, you are not touching the dentin. At this point, you are still going to use the primer from the center, or only the bonding?
Absolutely not. The primer is high hydrophilic material, so I prefer to don't. When I am sure that my preparation is completely in enamel, I prefer to treat with acid the cavity, but don't use primer, and to use immediately
the bonding. Yes, because that will be the best approach. Primer is highly needed for the dentin because of the moisture.
Yes, but if I'm not sure, if I think to discover some little island of dentin, please immediately put the primer, otherwise you risk bigger sensitivity problem. Overall in small cavity.
I heard even about the procedure when it's recommended, for example, if you have a cavity and if you are really precise enough to apply primer only on the dentin and then apply bonding both on the...
Yes, this is a very nice philosophy, but I told you before, I am a real dentist, so for me it's impossible to follow these metaphysical messages, okay? Because I have to work, normally I have to treat 10 patients for day, and I have to, at the end of the day, I have to do 20 restorations for day. So all these messages are very beautiful, but in my opinion, completely unuseful for a real clinical day. And they produce a lot of confusion in the general dentist.
I will admit I tried a few times. I totally failed. It's impossible.
Yes, but this is a stupid message, because the primer is so hydrophilic, so it will go all over the place. Immediately, spontaneously. Okay?
And you cannot just touch the dentin without touching the enamel.
So you can try to do anything you want to be philosopher, but I'm not Greece, I am Italian, so I have to work, unfortunately.
Dental philosopher, so...
Yes, dental metaphysics.
That will be the next... The next topic.
I prefer to be simple and effective, because I have to treat patient and not to make cases.
We talk about direct reconstruction.
Yes.
When you are cementing, for example, a veneer, you are making an indirect case. You are still using the same bonding, or you have different types of bonding for different procedures?
No, absolutely not, because I want to make my life simple, my daily clinical life very simple. So I prefer to standardize the adhesive procedures, okay? And I want standardized and very simple adhesive procedures, because more you make the things complex, more you predispose yourself to make mistakes during the procedures. So the real secret is to standardize completely the protocol, and to cut all the stupid message around the world, and to arrive to the juice of the addition, okay? Very few steps performed in the very serious way.
So your secret message, not secret because you are sharing with us here, will be just choose a good adhesive.
Choose a good adhesive, and overall you can choose anything you want, because you can choose anything you want, but follow very well the instruction. Don't be artist, and overall have a good learning curve to understand which kind of product are you using, okay? Please don't change any weak addition, because otherwise you will solve your problems. You will increase your problem.
Another difficult topic in dentistry, about the isolation,
Yes.
about the rubber dam, and sometimes about the impossibility to place a rubber dam, for example, when you are cementing veneers. In
Yes.
some cases, when you have a margin that is well...
I will be really sincere. I'm happy about these questions, because sometimes I look overall on Facebook University, amazing exercise of style, okay? And these crazy isolation are performed spending 1 or 2 hours of work. In my opinion, you can do it one time for years, not every day. So sometimes I am forced to create micro isolation with retraction cord, but sometimes depend on the margin, okay? Overall for single, not for 6 or more teeth, but sometimes for single tooth discolored, you have to hidden the margin, and you go frankly
you have
under
to go
gingiva.
deeper,
So in these cases, don't try to destroy periodontum with clamps, unreal isolation. It's much better to put 1 or 2 retraction cord in a gentle way in a perfectly sound periodontum. It's the best way to cement these critical veneers, for example. In posterior region, the topics is the problem is a little bit different, because you have a lot of saliva, and so my advice is, if you have the right condition to do adhesive dentistry in posterior region, do adhesive dentistry without any problem. Push the limits, okay? In my opinion, the limits now, in this historical moment, is not the treatment plane. It's the possibility to allow to the prosthetic structure to be cemented in adhesive or not adhesive way. If you can assure an adhesive cementation, you can do without any problem with, for example, an overlay. And you can do really extreme cases, okay, under rubber dam, if you are able to cement under rubber dam. But if you are working in posterior region without rubber dam, please change treatment plane and make a crown preparation, because it's much better than a bad overlay cemented around the saliva.
Yeah, I totally agree with you with the part with sometimes when you have margin that it's...
Yes, no, the deep margin elevation, blah, 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 was this thing, please, is much more easy. It's like to hidden the dirty on the carpet, okay? It's much better, or you are able to do a good surgery, okay, to expose margin, or is much better to change treatment plane, because we live in a period where the people are shy to make a crown. No, the crown exists, a retentive crown exists. I do every day. My patient doesn't die with a crown in the mouth. I prefer to do a crown, a beautiful crown, much more than a sheet adhesive of fake adhesive overlay cemented in the blood, in the saliva. Please, I want to be really clear in this message. When you have the right, when you don't have the right condition under isolation point of view, please change treatment plane and go with a conventional retentive prosthodontic treatment, because your patient doesn't die.
Yeah, I totally agree with you.
Yes.
What happened to me? Like 2 or 3 weeks ago, I was cementing some veneers. I was unable to place a rubber dam. I tried a lot with a retraction clamp. I only caused a lot of bleeding. It was a mess.
Yes, you produce a lot of bleeding, you destroy the periodontum, and you create a lot of problem to the.
And
the
I will admit that was from beginning to the end. It was a case really well documented. It was an extreme case, and I said, okay, if this case will work, I will save it. I will post it. I will present it.
In my opinion, the people start to be tired of the super show.
Yeah.
Okay, I am a simple and real dentist. He is a dentist. He have my same problem in his daily clinic. So sometimes you can reach the state of the art, or you are ready to change treatment plan, or you have to say to the people the sad truth. Sometimes overall in anterior is impossible to reach a perfect isolation with rubber dam. Sometimes it is really easy, and is stupid to don't use rubber dam. But sometimes patient don't allow you to spend 2 hours
just for isolation.
Isolation.
It happened also just to place retraction cord before cementing a veneer.
Yes.
And then to have like a nightmare, try to remove, because that retraction cord got impregnated with bonding, with cement.
Yes. No. This is quite normal. But sincerely, I don't have this problem, because I go inside the sulcus with in a gentle way with a probe. I use a cord not so it's very raw, so it's easy to be clamped with the probe, and
it happened only once. Then I only was single tooth. Maybe
yes, very often single tooth are much more dramatic than the 2, 3, or 4 tooth.
Since then I changed to use Teflon tape for retraction. I don't know if it's
yes, but Teflon is another great material, but he need a very large learning curve to be used in the correct way.
I know you have to use with 2 instruments. You have to get a lot of help from a dental assistant. It's really hard to work with it. What I want to talk right now. I was talking with you in the beginning, in the break, about cementing onlays, overlays, especially when you have excess cement in the proximal area. Especially when that cement
Today he won't kill me, I am sure. I need to preserve myself, because this evening I have to eat a great Romanian ciolan. Okay, this is a very hard topic, because very often I believe a lot in direct adhesive dentistry, so I minimize conventional treatment plan, and I do a lot of adhesive dentistry overall in the posterior area. So I know what he want to tell me. The cementation, in my opinion, is the most underestimated moment of all the restorative adhesive procedures, because it's the most critical cement. Now, with not retentive preparation, it's very easy to have a good adhesive preparation for indirect restoration. I published with Professor Permans and Professor Van Merberg 2 articles about a new way to think about the real adhesive preparation, not related with retention, because we have to forget retention when we work adhesively in the posterior area. But the most critical moment, in my opinion, remains always the adhesive cementation and the removal of the excess of the cement, okay? Because we standardized the preparation, we standardized adhesive procedures. The most critical moment remains the removal of the excess of cement post-polymerization. This is a big drama. And I invite you, if you want follow adhesive procedures, to pay a lot of attention to removal any kind of excess before the polymerization. But after polymerization, you have to start to search, and you will find without any doubt, about the polymerization, the polymerizated excess of cement, adhesive, the squeeze everywhere, overall in the proximal space, and overall in the neighbor tooth. And to do it, please check always the presence or not of this excess of cement with a good RX, post-operative RX. You will discover how many times you leave completely polymerized adhesive materials under gingiva. Okay.
What can we do then?
You have to be patient, and you have to go to search for it, because sometimes you are completely sure, this time I clean perfectly. I do RX, fuck, the cement, the excess. You have to search with RX, and please do always a stupid bite wing to search this excess. You will find for sure, I can swear you.
The fact that I'm not the only one that has this issue.
And I pay a lot of attention in the finishing of the interproximal area after the cementation, because this is the most critical point of all the restorative complex.
You are using finishing strips to?
Yes, always. Yes, I always use before metal very low granulometry strips, and after the classic
like a celluloid.
Yes, the classic plastic strips, fine to try to gloss the interproximal area.
I think this will be the last question. In the case when you are preparing, for example, also for onlay, you are preparing in this session, you are taking an impression or a digital scan, it doesn't matter, but you have to temporize, You have to place something there. The question will be, you cannot place any kind of material there. The ideal will be to have something that you can remove very easily. Otherwise, if you are placing something that it's really adherent to the cavity, you start to make adjustment to the cavity.
Yes.
You are using then sandblasting to clean the cavity? What you're
using? No. For example, this kind of restoration, overall, I love is my philosophy, okay? I love to prepare not retentive preparation for overlay on the top, okay? So I need to provisionalize this kind of restoration. I have two ways to provisionalize this kind of restoration. The first, I love to use IDS procedures to close the biological system of the tooth, okay? And after, on this IDS, I put 2 drops of liquid rubber dam to block the position of the tooth. This kind of dentistry need to be performed in very, very few days, okay? So my technician already know that when I send him an impression, I have to receive in the office the overlay at least in maximum 4 days, okay? In this moment, my preparation is provisionalized, blocked just the extrusion and the mesotrusion movement with 2 drops of liquid rubber dam on the distal side and on the mesial side. Okay, this is much more than enough to stabilize the preparation for 3, 4, 5 days. But don't, please, if your technician is not able to give you overlay in 4 days, you have to change strategy. Otherwise, you will, during the cementation appointment, you will have a movement of the residual dental structure.
So that will be the case when you receive the only from the dental technician. It will not fit. You'll have a lot of
99% of the movement are from distal to mesial, in mesialization of the preparation, or mesio extrusion, okay? Mesialization and distal extrusion, okay? This is the most classical movement of the tooth. Then you have to try to honey bite this kind of movement. Of course, it's very simple for 4 days, okay? But if you want open yourself to do a real adhesive dentistry, please ask to speak with your technician, because you have to receive the overlay at least in 4 days.
Thank you for your presence.
Thank you very much.
The interview with...
No, another important question. Yes, with the day you have to cement the overlay need to be cleaned, okay? But not to be sandblasted, to be cleaned. So one thing is cleaned the preparation, another thing is to sandblast the preparation, because if you use the sandblast to clean the preparation, the risk is to eliminate this thin layer, the functional base of the overlay, the IDS layer. So when my patient is not able to clean very, very well the preparation because he have a fear to touch this tooth, this residual part of the tooth. Sometimes I found a lot of calcified tissues. Please don't start immediately with sandblasting to eliminate this layer, because the risk is to eliminate the IDS layer, that is the functional base to have the overlay on the top. You can treat this kind of situation with air polishing, that is completely different to sandblasting, with powder, not glycine because it's not so effective. I prefer to use sodium carbonate 30th generation because it's much more fast and effective, without any risk to insult the hybrid layer. And immediately after the isolation, I can sandblast to increase the mechanical retention of the overlay on the top.
Prophy paste will be enough for this case, just to clean it? You will not go...
I don't like so much. I prefer, I love desperately air polishing. I have on the chair and I use 300 times 4 days. It's very easy and very effective, okay? Then if you have to do a good investment for the quality of your dentistry, please start to use air polishing for a lot of clinical situation.
You respond a lot of questions. You gave us a lot of tips and tricks. I'm more happy to see that I'm not the only one having issues in real life.
No, listen, there are two categories of people. The speakers, the blah, blah, blah speakers, that they do one perfect case in the Saturday morning with a lot of light, with a lot of assistance when the office is closed. In this condition, all of us become the best dentist in the world. And there are real people like me, like you, that have to work in a real environment with a real clinical time. And I am tired to show to the people the state of the fake state of the art, because it's realized in a closed office with 3 assistants in the Saturday morning. This is not true, because increase the frustration for the people that follow us.
That's true.
I prefer to show to the people a real daily clinic, maybe not perfect, full of mistake, but at least the real.
Thank you again for your present. We are waiting for you at the Ciolan cu Fasole.
No, I am waiting my Ciolan cu Fasole. I was there just to eat this one, so it's time to go to eat.
Thank you
very much.
Thank you again. It was a pleasure.
Thank you.
See ya. Bye bye.